Hello, everyone. Thank you for joining me today. My name is Martin Campbell, and I am a second year internal medicine resident at Emory University School of Medicine. Today, I will be presenting a case titled Catheter Associated Cryptococcal Peritonitis in an Immunocompromised Patient with Systemic Lupus Erythematosus. A 26-year-old woman with a history of lupus who was on prednisone, complicated by end-stage renal disease from lupus nephritis, and on peritoneal dialysis, presented to us with a 1-week history of pruritic rash and abdominal pain. Her rash was first noted to be on her lower right back and gluteal region, and then 4 days later, she also noted the same rash on her lower right ankle, which made it difficult to ambulate. This rash was associated with burning pain. She also had abdominal pain that was diffuse, mild, and nonspecific, and she did not have any associated nausea, vomiting, diarrhea, or constipation. On physical exam, she was noted to have a normal temperature, an elevated heart rate at 150 beats per minute, an elevated blood pressure. She was slightly tachypnic, and she was sitting normally on room air. She was in mild distress from intense pruritus. Her cardiovascular exam was notable for irregular rhythm, a 3 out of 6 holocystotic murmur at her left lower sternal border, but she did not have any lower extremity edema. Her lungs were clear bilaterally, and her abdomen was mildly distended and diffusely tender. Her PD catheter was in place, but it did not have any evidence of infection. On skin exam, she was noted to have an erythematous pustular rash and plaques noted in clusters in a linear distribution along her lower back and right gluteal region, with crusting. The same rash was noted on the lateral malleolus of her right lower extremity. These rashes were not tender, and it did not have any foul smell or purulent drainage. Her initial labs were notable for an elevated white count of 13.8, as well as a slightly low hemoglobin at 10.7. She also had an anion gap of 19. Her creatinine was elevated at 11.62 with a BUN of 83. She also had elevated inflammatory markers with an ESR of 105 and a C-reactive protein of 138. Her liver enzymes were also elevated with an AST of 179, an ALT of 173, and an ALK phos of 253. Additional testing revealed a body fluid sample of her peritoneal dialysis effluent that showed 2,900 white blood cells. Of those white blood cells, 75% of those were neutrophils, 8% were lymphocytes, and 17% were macrophages. We cultured her body fluid sample, and it grew 4+ Cryptococcus neoformans. As far as her clinical course, her PD catheter was removed, and she was ultimately transitioned to hemodialysis. Her blood cryptococcal antigen was negative, and her blood cultures had no growth. We consulted the infectious disease team, and she was started on IV mycofungin, but she was later switched to IV amphotericin for better cryptococcal coverage. Her abdominal pain resolved within 24 hours of initiating therapy, and her repeat peritoneal fluid analysis showed decreasing numbers of Cryptococcus neoformans and decreased leukocytosis. Her rash was ultimately diagnosed as varicella zoster infection, and she was initiated on IV acyclovir due to possible disseminated disease, which was a concern of ours due to her elevated liver enzyme. Hospital day 4, her sepsis resolved, and she was transitioned to oral fluconazole. She was ultimately discharged on valacyclovir and fluconazole with plans to complete a 3-month course of antifungal therapy while remaining on hemodialysis for at least 6 to 12 months. She was discharged with close follow-up in the infectious disease and nephrology clinics. Now I'm going to talk to you about a few takeaways from this very interesting case. Cryptococcal peritonitis is a very rare occurrence. Only 61 cases of this have been reported between the years 1951 and 2012, and a quarter of them have occurred in peritoneal dialysis patients. Given the fact that we don't see this all that often, it can be hard to recognize. And it's very important to initiate therapy as soon as possible, given the high mortality rate of 15%. In any fungal peritonitis, PD catheter removal is important and indicated. As seen in this case, immunocompromised patients can have rare causes of peritonitis, which require specialist consultation for appropriate treatment. Here are my citations, and thank you. That concludes my presentation.